right, so let me start. So this is an interesting case. This is, how old was this patient? This patient is 88 years old, had a cough, and you can see the trachea is big, but it also kind of has this unusual shape. It's kind of flattened a little bit out, but so a nice case of tracheomegaly. But then as we look, we'll start seeing these funny cystic spaces in the lungs, and they seem to be around the bronchovascular bundles. But then as we go out, we also see that there are some dilated airways that seem to go into these spaces. So there's bronchiectasis as well. Of course, patient's very short of breath, can't hold his breath. So, this is sort of a Meunier-Kuhn-like pattern with the tracheomegaly. Interesting, the main bronchi look more morphologically normal, sort of combined with some more peripheral airway stuff going on. I don't know why all these cysts are here. Patient has some obstructive physiology. So it's just a sort of, I think of it, Meunier-Kuhn more as a spectrum of airway abnormalities affecting the large airways. I don't know, Travis, if you have any thoughts about this case. But at first I was trying to figure out if this is like a Williams-Campbell, which is on that spectrum, but the airways themselves aren't that big, and I think these are just cysts around them for whatever reason, maybe chronic obstructive
Right.
physiology. Let me make a
Yeah,
correct.
because it looked like in some of those maybe at first when you were showing, I was thinking maybe they were dilated airways, but then some of the ones, particularly in the lower lobes, clearly you can see the airways going around those cysts
Right,
or the cysts around the airways.
right.
Yeah.
I guess the main bronchi are a little funny looking, and they're kind of a little bit big on the minip. If we go back to and we look here, let's turn that off. Yeah, I mean they're like, here's
Is
an
this
airway going.
ammonia?
Well,
Is this
that's what I think
ammonia
it is.
Coon?
Yeah, it's a Meunier-Kuhn, but it's just got these funny cysts, which I guess is just from chronic
Yeah,
air obstruction.
yeah. It's almost like a little emphysematous cyst, but due to focal obstruction versus,
Yeah,
anyways.
because here's a thickened airway going right through the cystic space, so kind of neat.
Yeah.
That was just kind of an interesting one. Um, this was kind of cute, and nothing terribly exciting, but this patient just had an obstructing lesion here. But you can see how much calcium is in this airway, and it's not a broncholith. You look at it, it's more amorphous, and there's clearly a round mass in here. Um, so this is probably one of the best examples of calcification I've seen in a carcinoid tumor. I've seen a few stippled ones, but I've not seen this much calcium in one before. It's a typical carcinoid, uh, and just presented because of the obstruction. But it's just kind of neat to see that much calcium. But there's not a lot of things other than broncholiths and maybe a metastatic mucinous tumor, a GI-GU tumor. You can see it sitting right there in the airway with a lot of calcium in it. So the literature talks about stippled calcifications in them, but this one definitely more than just stippled. Um, this case is kind of crazy. So this guy is 75, treated for pneumonias. I don't have older imaging, but we got these outside images sent to us eventually. And you can see he's got this sort of mass-like consolidation in both lungs. If we look on the lateral, it's backward. You can see it's both anterior, posterior. So, I mean, it looked like community-acquired pneumonia, but didn't quite fit because given a couple rounds of antibiotics, didn't get better. So they did a CT scan at the outside facility, and you can see there's pleural effusion, but then sort of this really, really extensive consolidation, some air bronchograms, a few cystic spaces, but pretty bland looking, pretty homogeneous. It's had some old histo, has a few nodes that are a little on the plump side, but nothing to get terribly excited about. And then if we look on the lung windows, we see a little bit of that consolidation up there, but then down here you can see it has really just abrupt margins, all these nice round margins, and there's not a lot of transition, sort of a narrow zone transition, normal lung, one little satellite nodule, but we don't see little Cheerios around it or other satellite nodules. So you think about adenocarcinoma, but this not what this is. Maybe around here, chronic blasto can present, but I'd expect the patient to be a lot sicker with this much disease. Chronic mycobacterial infection, but again, they usually have small nodules with infection. So this patient got a biopsy, and this is extranodal marginal zone lymphoma, so MALT lymphoma, just confined to the lungs. But it's, I think, one of the more extensive cases I've ever seen, just presenting as just multilobar consolidation. And it preserves the airways, which is typical of lymphoma, but other than that, I don't think I would have come up with lymphoma as a diagnosis other than in a differential for persistent consolidation. And then this is the coolest case. So this case was a transfer not that long, well, a while back, but patient was transferred to us for acute PE decompensation with right heart strain to be sent potential lytic therapy, and I think Travis and Seth, once you see it, you'll know exactly what I'm going to talk about. So here's the scan, and you can see this is this parent filling defect here. And as we go down, we see this fluid level in the pulmonary artery. We see poor mixing in the left atrium, and then no contrast at all in the right lower lobe, and then it kind of drops out here. You'll notice the right heart's big. He's got an aortic stent valve in place. And if I change the windows, you'll see that this is just a beautiful example of smoke. There's the contrast whiffs through here. I don't have it. I didn't load it because I'd have to crop it down. But if you look at the bolus tracking numbers, they timed off the pulmonary artery. We always time off the left atrium, but you should see progressive enhancement. It's sort of like it looks like a sort of a exponential curve or parabola or something, and it was perfectly flat. So there was hardly any forward flow, and they had the ROI in the right place and a good bolus coming in. So his EF is about 15% of his ventricles. So very poor cardiac function. You can see the right atrium is just contrast going wherever it can go. So this is all smoke from poor cardiac function, not PE, which is a good thing because they were going to take this guy to the cath lab maybe and do some things, but make sure to go over it with us first.
Wow.
Yeah, it doesn't help that he's got bad lungs too, emphysema, maybe some fibrosis.
Yeah, that chronic pleural thickening and whatnot.
Yeah,
Whatever
so I
else is
mean, he's
going on
got
in
just
there.
so many strikes against him, but it's just a reminder. When you see this contrast, filling defects that are this wispy, it just doesn't quite fit. All right,
Yeah, I'm happy to go.
all right.
I've got a whole load of cases here, but Seth, you've got some too?
Yeah, I got 3 or 4 I can show,
Okay.
but mine are
Okay,
quick.
it's just the three of
All
us.
right.
So
Well, we're going to start again on the PE theme. And this is a patient, this is an outside CT. And as you can see, they're in their 40s. The bolus in the pulmonary arteries is sufficient. But like I tell the residents and like we've discussed on here before, I always get very, very nervous that there's no contrast in the left heart. And you know, even when you're timing off the aorta, there's got to be some explanation for it. And in his case, there's nothing chronic. His LV looks okay. And you notice there's a sizable pericardial effusion that's intermediate attenuation. And his ascending aorta, not only is it huge, it's about 6 centimeters. There's a little bit of just dirtiness in the fat there in the ascending aorta. So this is at least the fifth one of these that I've seen that is, as we'll see, fortunately he survived because it wasn't for another 24 hours that they actually did the aorta timed CT. And in the meantime, I was trying to figure out, because this was all outside, like if there was an echo that showed a flap in the ascending aorta or not. But either an MI, he doesn't have any coronary calcium, or with an aorta that big, you have to be worried about an acute aortic syndrome. And if I can get to cut to the chase, and here's the next CT that was done. And sure enough, there's a type A dissection with a big entry tear in the ascending aorta. Now, I don't see any of the flap prolapsing through the aortic valve to explain why, the reduced cardiac output. I suspect it's more just tamponade physiology from that degree of pericardial fluid that he had. It's interesting too. His left atrium is so collapsed, and I'm curious what you guys think of that in terms of, is that just a consequence of the pericardial effusion? I don't always pay attention to the size of the left atrium. I mean, if he's got reduced left ventricular outflow tract, you might expect it to back up and cause dilated left atrium, or maybe it's just because there's no space in the pericardium for it to dilate. But this is it's not surprised when we saw the follow up because he had been transferred here for surgery and fortunately survived.
I think your
But yeah,
pericardial theory is probably the best because that left atrium just can't fill.
yeah,
Because there's good contrast in the lungs, so there's plenty of flow
yeah,
coming into the left atrium, which just has nowhere to go.
yeah. But yeah, I always get scared when I don't see contrast. And here you can see, just a quick measurement's over 6 centimeters. And you don't even have to measure it. You can see it's twice the size of the descending aorta. All right, this is a nice radiograph that one of my fellows saw the other day. And there was a prior radiograph. Well, I show them both. I mean, they're both unchanged and they both show the same thing. And this is one of those ones I think is probably just for us, just pattern recognition. The prior one that was read as port catheter in place, otherwise normal radiograph. And I think everybody can see this is not a normal radiograph. And with the indwelling port catheter, you wonder what the patient's chronic issues are. And it's interesting, it's a little bit more medially, the tip of it's a little bit more medially deviated than we expect. But you see abnormal convexities, superiorly a big, juicy thing right here in the region of the azygotharch. And then I think the more subtle finding, which was a nice pickup too, was down lower. And of course, this all turns out to be secondary to SVC obstruction. And so dilated azygos vein, some dilated collaterals up higher. You can see the left brachiocephalic vein is a little dilated there. Um, and, no surprise, this is what's corresponding. So it's one of those ones you can almost make a diagnosis of SVC syndrome off of the plain film. Now, in this case, for whatever reason, the SVC is just a little bit more medial, but you can see it gets super narrow there. Oh shoot, I forgot to download the timing bolus. But it's really interesting because at first when I was looking at this, I was thinking that this patient just had a lot of calcium in the wall of their ascending aorta, but this is all venous collaterals. And it shows up nicely on the timing bolus series because there's nothing around the aorta. And then you see these just fill in. Oftentimes we've shown the cases where you have these spontaneous collaterals that fill into the left atrium. And you may have a couple of those, like right here, but I don't think I've ever seen like this pronounced of a circumferential filling surrounding the ascending aorta. Have you guys seen that before
Not
or
there,
noticed it?
Not that much. No, definitely
and
not.
not
Yeah,
anywhere else.
I have to, no, and I have to go, I have to remember I'll pull up and retrieve the timing bolus because it just shows it nicely. There's nothing there on the first image. And then right as that contrast starts to hit, it just lights up around the aorta.
Travis,
So,
can you show the
uh,
the catheter course more proximally to where it was inserted? Was it a jugular or a subclavian?
it's a internal jugular.
Okay, that's why it was above the clavicle then.
Yeah. Welcome back, David.
Oh,
Good to
my
hear your
pleasure.
voice.
um, but it's usually they don't try to place these things into jugular veins, these port catheters. So I wonder if generally they're
In,
put in the
in interventional, most interventional radiology, tunneled port catheters are still placed in the IJ.
in
Like
jugular.
surgical ones are
Okay,
definitely subclavian.
okay,
And then here's just more dilated azygos and hemiazygos showing that subtle paravertebral widening at the diaphragmatic hiatus.
the catheter never went into the azygos vein though. The catheter was in the cava, right?
Yeah, yeah,
And then
yeah. And
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 how far down can you follow it?
there's a little bit
How
of catheter associated thrombus there, and then it gets super tight just at the superior cavoatrial junction. I think there's a little bit of thrombus extending into the right atrium as well. So,
got it.
and whether it's completely, whether there's a wisp of contrast getting around that catheter or not, obviously the bulk of it is going through the collaterals. David, I don't know if you have any cases or not. I'm going to keep going because I know Seth does.
I do not.
All right. It's weird how these cases kind of come in clusters, but this is a young patient. I think they're less than or around 20 years old. And you can see they have this abnormality in the right hemithorax. And of course, when you look at it, you realize that it's involving bone. You've got rib coming around, rib, which should come around and just goes into this whole thing that's expansile. And he was having pain. And so on the CT, you'll see a few things. There's a subtle little, there are a few internal mammary lymph nodes on the right side that you can see here, and some axillary nodes that are all involved. But this is clearly a malignant appearing lesion. It's destructive, permeative, expansile, a lot of soft tissue surrounding the bone. And so this was biopsied, and this was a diffuse large B-cell lymphoma that was involving the bone primarily, but also involving some of the intrathoracic lymph nodes, like I showed. A couple more
That's like
internal
the
memory
case I
nodes
showed
here.
last week that presented as a chest wall
Yeah,
mass.
yeah.
That's so cool.
Well, that's what I say. It's weird. These show up in clusters, right? And then, I mean, with treatment, it's so interesting how the rib, there's still some asymmetry there, but it has substantially improved. Now there's that one, and then like within a day, I saw this, and it was a follow-up CT on this patient. And this is another patient in their 20s. You can see they have a fairly young-looking skeleton, and they have an expansile lesion of a rib, which has been there for 3+ years. Now this one, you know, still you can see well corticated margins. And this is the more common rib lesion, I would argue, that we occasionally see. And this is more of a do not touch lesion, even though they were referred to oncology. She had no oncologic history, but in this case, it's expansile. There's still cortex. There's no soft tissue around it. She was asymptomatic. I'm not even sure how this was discovered, but they didn't biopsy this. They've just been watching it, and it's unchanged for 3+ years. And so presumably this is just monostatic or fibrous dysplasia, as we often see in the ribs, as an expansile, non-destructive, much more happy looking thing than that last case. But it was interesting. It was one rib below on the same side. I haven't seen, it's been a few years since I've seen a big one that they actually resected. Um, okay, this patient, I think they're, 27, another young patient comes into the ED with this radiograph, or by this time they've had a pick placed, but around the time of their presentation. And you can see a lot of fairly discrete nodular opacities, bilateral, more nodular than reticular. I try to get the residents not to just broadly say reticulonodular. And this patient had no medical history other than just some worsening symptoms, cough, fever, some B symptoms as well. And you can see it's just diffuse nodules. They had no history of primary lung cancer or primary extrathoracic malignancy. And a broad differential was thrown out by my colleague that interpreted this and included, just because they didn't know the history, but included if the patient's immunosuppressed, this could be Kaposi sarcoma, and this actually turned out to be Kaposi's. And I don't know the last time I saw, you know, especially here at like Duke or at UCSF, a patient come into the ED that had undiagnosed full-blown HIV/AIDS. But this all turned out to be Kaposi's. And I think some of these are the buzzword, the flame-shaped lesions that we see, some of these, but really a lot of these nodules are just in a random distribution, even though maybe some of them tend to cluster along the bronchovascular bundles more. But I don't know, when was the last time you guys saw Kaposi's?
Once.
De novo? Uh, Probably a
Saw one
couple
a
of
year
years.
ago. So
Yeah,
this was AIDS defining. That they didn't have the
yeah,
diagnosis of AIDS until they worked this up.
correct. Until they came into the ED with this. This was their AIDS defining illness. They had no history. So apparently it's occasionally still out there. This is a quick, I was talking to Chris Cummings last year I think at RSNA because he gave a talk on pitfalls in FFR. We've been doing heart flow at Duke for years. We were starting to do it at UCSF before I left, and now I understand there are competitors that are coming to market, if not already on market, for FFR CT. This lesion, this is a 75-year-old, and he's got a lot of calcium, as you can see, in central, or the proximal portions of both of his coronaries. And this was read by a colleague, and I think correctly, it was said this was 30 to 50% in the left main. And our heart flow recommends, and I don't know if I always agree with it, but 40 to 80%, they say send for FFR, or 40 to 90%. I'm not going to spend time MPRing it, but you can see there's still lumen here. There's probably a little bit of blooming artifact from this calcium, but this
That's
is the
very,
FFR that we got back.
yeah.
And yeah,
I could show you
so
3 or 4 of these that are like this.
yeah, and so yeah, just saying that this is a critical stenosis in the distal left main. And then, you know, I found out about this when the cardiologist went to the cath lab and emailed us and say like, how'd this get screwed up? Because they did catheter FFR, invasive FFR, and it was like 0.95. There was nothing actionable. And their anatomic stenosis, they estimated it as 30 to 40% on cath too. So it's not like we were way off on the anatomic. It's just this was a floridly false positive case. But Seth, you've
Yeah.
seen this a few times?
Yeah, I think I showed a case here maybe. And the issue is that you remember you have humans drawing lines, right? I mean, it's still
Yeah.
humans drawing lines around coronaries, and clearly they made a mistake here. They clicked outside the lumen or did something. And if you get something that, I mean, what they tell you is if you get something that looks this wrong, you're supposed to like send them via an email or like a link on the thing saying quality control because it's got to be wrong. I don't know how to describe it. Like on the when you log
Hmm.
into the HeartFlow website, there's a way where you can, if a study looks like this, you can QC it and have someone else at HeartFlow send it back to
Okay.
them, have them review it. Because if you look at the stenosis here, I mean, it's like pinpoint 99%
Right.
on what they're
Right.
modeling, and you know that's not what it is. But we've
Yeah.
we've we've sent a couple people to cath at UCSD off clearly erroneous heart flow
Like
tracings.
this.
Yeah,
Yeah. I mean, yeah, it's a good quality study. And yeah,
yeah,
I mean, it's just because it's a left main lesion. But yeah, I thought this was interesting.
yeah. No, it
That's good. This was a few weeks ago, but we'll send it for QC.
yeah. I would send it. There's a way on there to send it back to them QC, and I didn't even know that existed. And because I wrote them after seeing a case like that, being like, yeah, I didn't read it, but someone else read it,
Yeah. Right.
and the cardiologists were like the same thing. Like, what's going on? This study is basically normal.
Right,
There's my
exactly. And yeah, that's how I got involved was on the quality side afterwards. It's
yeah,
like, what's going on?
yeah.
Yeah, that'll be okay. I'll reach out to them. Two more. This was done for an unrelated reason, cough or something. They found this anterior mediastinal mass, as you can see. And this was all done at an outside hospital. And I've got a question, I just want to poll the group on how you would manage this because, to me, there's clearly some macroscopic fat in there. And this is one of those ones that looks like a cystic teratoma. At the outside, they said, oh, this is a mass. They did a PET, and
Yeah.
there's a little bit of activity along the wall. And so then it's like, well, this, there could be malignant elements. We want a biopsy before we take this thing out.
Why?
And yeah, I guess the question is, you know, would you biopsy this I mean,
I mean, you'd argue it needs to come out anyway. It's pushing on the
Yeah.
right,
heart.
I mean, they're going to take it out anyway. Even if it's a teratoma, they're going to take it out, which it is a I
right.
mean, I'd be shocked if it wasn't. I mean,
Yeah, it was all mature elements. It was a mature cystic teratoma.
yeah.
And I think especially in these, you run the question, there's always that risk of like spilling fatty
Mhm.
contents during the biopsy or whatever. I don't
Yeah, I
know.
don't know why he would biopsy it. I mean, um,
They don't
Yeah.
know.
yeah, but
Yeah.
um,
Yeah. I don't know. I think a lot of times too, I don't know what the discussion is with the patient. If they're told they might have cancer and, they want to know or what, I don't know. I mean, I just think that like if I see this and talk to surgeons, just like there's the flow chart of ending up at resection doesn't change regardless of what the biopsy shows.
yeah, and it's
Yeah,
benign. I mean,
Yeah.
that wasn't helpful either.
Yeah. Yeah, I mean this inferior portion is a little interesting that kind of juts out a little. It's not perfectly circumscribed, but it doesn't look like
Hmm.
it's invading any adjacent tissues. It's just kind of a weird peduncular or weird lobulated shape. All right, and then one more. This is a trauma case, and you can see that there's some. he's intubated at this time. And whatever this external fixation stuff is he has, this was an MVC. You can see there's a sneaky thing in the left upper lobe that, of course, is mostly obscured. Now, of course, this was a level 1, so he was on the CT scanner by the time this was even seen. But you know, I think this is a very fun case, for lack of a better term. And the initial impression from the trauma radiologist was that this must be a lung laceration with air fluid levels in this left upper lobe, and even raised the possibility of, could there be some contrast extravasation into this area right here? And I think, hopefully everybody on here is
Did they take
experienced
it out? I
enough to
hope they took it
realize.
out for proof.
No,
Did
no,
they
no, no,
take
no, no.
it out?
No, one of my colleagues, saw the radiograph the next morning, and called me and was like, before I call them to tell them they're crazy, I just want to make sure I'm not crazy.
Yeah.
And of course, yeah, my colleague was like, yeah, right, this is bronchial atresia. And it may be one of these hybrid, I don't know, a hybrid lesion, but there is no airway going to that
Hmm.
apical
Yeah.
left upper
Yeah.
lobe.
No, I know. I was
Yeah,
just
and you
hoping
can
they
see, right,
There's
did a
right.
lobectomy to get a beautiful pass.
and there's some
Yeah,
CPAMY looking tissue around
I
it.
was wondering too if it was like a CPAME thing too with the,
yeah, that's
but
what
I
I was
think
saying.
if
It's
it's
There.
probably
bronchial
one of these
Well,
atresia,
hybrid,
yeah,
yeah, this
yep.
hybrid bronchial atresia plus CPAM, right? That's, yeah, but not trauma. And this guy clearly looks like he's got a little emphysema, probably a smoker too. I don't know, but yeah, not trauma. It's, I'll have to pull up a case. There was one we had a few months ago, and I may have shown it. I don't remember. Actually, I think I did show it. It was the one with the trauma where the guy had rib fractures on the same side that he had fibrosing mediastinitis that was undiagnosed. I'll have to look and see if I still have that one
I
on
don't.
here.
I
Let me
mean, I
show it
haven't been
again,
out to
but
all the conferences, but I didn't see that one. That sounds interesting.
yeah, yeah. But this was right. So some sort of do not touch congenital C, bronchial atresia plus probably a CPAM. I agree. And you guys agree with the CPAM part too.
That's
Cool.
really cool.
All right.
All
And
right.
good news
Thanks,
for the
Beth.
patient. So I will
Yeah.
stop there. And Seth, while you're showing them, I'll try and pull up the other one I have,
Yeah.
that other fibrosing mediastinitis.
Okay. This is uh, just not the most interesting case, but so here's a guy with fibrosis, which is interesting. This is an older study. What's kind of cool is how it a little bit evolved here, but nonetheless, here it is now. The last study was about a year before. So you look at this. There's subpleural sparing. I think many of us would call this. I don't know. I mean, I would call this probably a fibrotic NSIP. It's too much subpleural sparing for me to be UIP. Nonetheless, this patient had a Envisia, and the Envisia test on bronch came back and was positive. The marker came back positive for UIP. Now we know that in Envisia, the marker, it's UIP for any cause. It doesn't mean IPF. It just means but it's not 100%. We know there are false positives and false negatives. And I think the sensitivity is like 95% or something. I'm not even sure, but they quote 90%, even though we've seen a lot of false positives and false negatives. Anyways, based on the somewhat different phone's ringing. Hold on one second. Sorry about
No,
that.
no,
Anyways,
back.
so the patient underwent open lung biopsy because of the differences between and we know that some cases that look like NSIP actually are UIP pathologically. But anyways, this was both fibrotic NSIP on pathology, on open lung biopsy, and a NSIP pattern on CT. So incorrect or inconsistent Envisia result. So it's just kind of showing that nothing's 100%.
You're saying there was a UIP or there was not a UIP element? It was
None.
all
It was
fibrotic.
all fibrotic NSIP. So, I mean, It's an open lung biopsy, 3 lobes. It was all NSIP, and we'll see what it does. If it be interesting to know that in the future, if it actually morphs into a UIP pattern, as we've seen some NSIP do, but everything except in a Visio was NSIP. And this is a, I don't know, I guess that's honeycombing. Um, this is the first time I've seen this. So this person has honeycomb cysts are big, a lot of ground glass. I think most of us would say this is probably, it's a older female, still can get IPF, but probably not. So the patient has rheumatoid, and I think most of us would say, yeah, that this fits with this UIP with some features that would suggest a connective tissue disease. But what's kind of interesting here is she also has these perilymphatic or peribronchovascular nodules throughout the mid and upper lung zones. And it turns out she has both sarcoid and rheumatoid arthritis. So she has a mixture of sarcoid lung disease and UIP from rheumatoid arthritis. So I don't think I've seen that combination before, and just thought it was a weird, you know,
She wasn't
nothing
on a
that
TNF alpha inhibitor or anything for her rheumatoid, was she?
was she. I'm sorry.
Was she on like a TNF alpha inhibitor? Because you or any other immunomodulatory therapy because they can get sarcoid reactions to their medications.
No,
Like,
she has. She's had like a known sarcoid slash
okay,
rheumatoid for like 30 years or like 20
okay,
years. But yeah, no, I know what you're saying. That is this a secondary sarcoid-like reaction? Um, but she, I guess, had a biopsy-proven sarcoid a long, long, long time ago before any of that therapy was out. So uh, this case, let's see. Let me go to the first one. Oh, this is kind of goes along with what Trout, and I just pulled this up because it's interesting. It kind of goes along with what. Uh, oh, wait, did I pull over the wrong case? No. How did that happen? Sorry, I think I pulled over the wrong case because this one doesn't have. This just looks like horrible, boring NTM, which we see every day. Clearly the wrong patient. Um, and that's weird. I'm surprised I pulled that over by accident. This is a case that just came up, and it's not too much of a diagnostic dilemma, but it's a nice example. So let me just sharpen this up. Um, so this is a patient who's had a left-sided pneumothorax. He is a middle-aged male, and you could see that there are these kind of lentiform cysts really along the underlying architecture, along kind of along the fissures, and there's a couple on the you can see there's a couple on the fissures here, and this is pretty classic for Bert-Hog Dupé. And sure enough, just read his history, and he's got fibrofolliculomas and all the skin findings of Bert-Hog Dupé. So a nice, just kind of classic Bert-Hog Dupé case.
And the
Nothing in the
kidneys,
kidneys. I'm sorry.
kidneys zero, right?
Yeah, I didn't see anything in the kidneys, but we recommended that he get a full kidney evaluation. But he's folliculin gene positive and all that good stuff. And then, oh, this is really odd. So, I mean, just looking at these nodules, this is super thin slices. These are the zero, I think 0.2s. No, those are 0.4s. So here are a little bit thicker slices. I mean, to me, these all look tree and bud. Or anyways, these have been around for a long time. These tree and bud nodules. He does have some emphysema. He is a smoker. And he underwent open lung biopsy. So he is a stone worker. So he underwent an open lung biopsy. And again, it really is all tree and bud. And the path showed mixed dust disease. So
Wow.
I I've never I don't get it. I asked the pathologist to send me some slides. Is it strikingly, impacted in the respiratory slash terminal bronchioles? Like what is going on? But he had a 3 lobe biopsy just right after the scan, and it wasn't like saying, oh, there's bronchial. It just said mixed dust disease um, in all 3 lobes. And I don't know. I mean I know the path's right. They're very good here, but have you guys seen mixed dust disease, silica, whatever, with tree and bud?
Do you, did it
No.
just not get into the lymphatics and it's just
That's
sitting
what
around in the
I don't
small
know.
airways?
I don't get it. I didn't pull over the old case. Yeah, and the nodules have been there since like 2018. And I don't know. Because initially I saw it and I saw the old. I'm like, oh, it's going to be, is he an IV drug user? I'm like, no, they don't look typical for IV drug stuff with these. I don't know. They're not as well defined, little ground glassy, some of them. And then um, here I've seen a couple of cases of that, panbronchiolitis or, you know, but then I looked at the history and I said, no way. And then I looked at the path results and it was all mixed dust disease. So I guessing it's particle size. I'm not really sure. I wrote the pathologist. I think I just saw this one yesterday and had him try to explain it to me because I don't get it.
So, it's mixed dust disease, but the question is, how is it distributed anatomically? What did the pathologist see? If he's got a bunch of stuff, whatever the mixed dust lesion is, if it's around airways, and that's why
That's what I'm
why you're
saying. It
seeing an
has to
airway
be
pattern,
right. It has to be larger that it's just impacting in the airways, the respiratory bronchioles, terminal
impacting
bronchioles,
or thickening the walls of
or
the
thickening the
airway,
walls or something.
interstitial.
And that's
Right.
why
But that's
I
not.
wrote him just yesterday and he said he'll get back to me. And I haven't heard from him today, saying I want to see what the path shows because this is really interesting.
Yeah, I think it's the distribution on the path that's going to be important, not what the lesion was, but how is it distributed, because I think the distribution explains the CT pattern.
Yeah. And I'm curious what the other mixed dusts are. I mean, I know most um, exposures are mixed. Nothing's really pure anymore. But anyways, I thought that was kind of interesting.
I've watched these guys do these outdoor projects, these landscaping things where they're putting down stones and they're cutting these things. Those guys generate clouds of dust, and they're not wearing any sort of protection.
Yeah.
It's really gross, and all sorts of particle sizes are coming off of those saws that they use. It's just amazing how exposed they are.
Yeah, no, I agree. I mean, I 100% agree. But yeah, I really, I just never seen one look like this. And I thought that had to be like something acute superimposed, but sure enough, I mean, these nodules have been there forever. So, anyways,
Very,
that's what I got.
very odd. All
Yeah,
right.
very, very.
Thanks.
Okay.